Hi, thanks. Thanks for inviting me to come talk. I'm very excited about this subject, and I am a primary care doctor in a federally qualified health center in Denver. I have, for the last 10 years, done all of the cancer screening quality improvements. So I go out to our clinics a lot, and I look at a lot of our barriers and processes and how we can make that better. And in addition to that work, I work with our multidisciplinary breast team. So I see a lot of people who have risk for cancers based on their family history. I field a lot of questions from our providers about who should be referred. There we go. Just wanted to address some of the problems we run into when we're talking about a resource-constrained system. We don't actually have a genetic counselor outside of our prenatal clinic, so our referrals are done by outside referrals to a hereditary cancer clinic. We, a lot of times, are juggling payer sources with our patients, so that can be an additional barrier. We just have to kind of piecemeal grants and send people to community services. I do have patients who come in with their 23andMe, and then I'm wrestling with how I am going to integrate that result into practice and hopefully get them some counseling. One of the things with our genomic syndromes is that they're rare and we don't recognize them very often. So an example would be a patient that I was taking care of who had a heart condition. I, a cardiologist, a vascular surgeon, were all taking care of her, but the person that actually made the correct referral was the nurse who was taking care of her child, who's also severely affected. And she came to me and said, I heard about this hereditary heart clinic. And so it was actually this nurse who was astute enough about what was going on in the patient's family to get her into the right system. It's also challenging as providers in urban health systems that we just really don't have a clear understanding of what point does our care leave off and at what point do we transfer it to a specialty care, especially when we're talking about a lot of the applications of genomic medicine that involve asymptomatic adults, tracking and screening when we risk stratify people. So Denver Health is an integrated health system. So what that means is that we have a number of outpatient clinics, but then we also have access to specialty care. With the Affordable Care Act, we greatly enlarged the amount of community health clinics that we had, and that has made a huge difference for a lot of people in terms of accessing acute care services, preventive health services, and we have pretty abundant access for those. If you get sick, you have a doctor and you can go see them. We work very hard at getting patients established into a medical home so that they have a place to go other than the emergency room when they have an issue. But one of the things that is part of our health system is that we have relatively constrained resources in terms of specialty care and a number of strategies that we've adopted to improve access to specialty care. So, for example, I can take a picture of a rash and send out a very formalized consult to a dermatologist, and they can get me a response. If they need to be seen in the clinic, they can get triaged into the clinic, but usually it's things that we can take care of in primary care. We do have antibiotic stewardship. I can page an infectious disease doc or a specialist and consult them about my concern or my patient. This is important because in genomic medicine, it can be a huge burden on our patients who already have jobs and resource constraints and geographic barriers to get to specialty visits. So if we are requiring that you have to go to this hospital and see this genetic counselor, and then you have to come back and you have to see gyn-onc, and then you have to see breast-onc, and then you have to get a GI consult to get a colonoscopy, this can be a huge burden on our patients. And the more we can centralize care or streamline their care and get the more services at single visits, that can really help people a lot. So this is one of our clinics. It's the Lowry Family Health Center. We have about 27,000 unique users. So this is one of our 9 health centers that are scattered around Denver, associated with our central campus. We have 15 full-time providers. I'll just draw your attention to the fact that 98%, almost 100% of the people we take care of are below poverty level. And the reason for that is that even if people don't qualify for public insurance, we can get them on sliding scale programs. So we work very hard to screen people and get them enrolled on programs that they can be on. So they can access basic services, But if you're on a sliding scale program, that can mean that to get an MRI, you have to pay $350. So for people who have low incomes, it can be a huge challenge downstream to provide care for them. This is an example of our Lowry clinic. It happens to be co-located with the refugee clinic in Denver. So not only do we have a lot of English and Spanish speakers who access their care, Nepali, Amharic, Arabic. So it's a really diverse population. One of the questions I was asked is, what are some of the ways that we provide care for diverse patients that helps them a lot? This is just a picture of the woman in the middle. Her name is Sherry Johnson, and she was actually a patient at one of our neighborhood health centers, decided she wanted to go into medicine and became a pediatrician, got our Career Service Award, was nominated by our medical staff for that award, and is taking care of children that she's taking care of. These are a couple of navigators. So navigators are non-clinical people who connect patients to care. Adrienne speaks English, French, Swahili, Arabic, multiple languages, and has a great deal of cultural expertise to provide care for the patients in the Lowry Clinic. And Kwang speaks Nepali and English. When you take care of diverse patients, many of them come from cultures where they access care when they're sick, and this idea of preventive health or wellness doesn't really take hold. And we were able to have patient focus groups that Kwang helped us mediate to find out from Nepali patients what their concerns were about screening, especially Pap testing, which is a pretty invasive test. And it was just a way that we provided appropriate care for patients that's more culturally appropriate for them. So our primary care providers in federally qualified health centers tend to have lots of competing demands. We tend to see patients that are really overwhelmed a lot of times with their issues. They've got lots of other quality improvement measures that we report on, and I'll show you what that looks like. It's hard in the context of providing primary care that you don't always know who you're supposed to refer, how you can screen. There are different tools for each of these hereditary cancer syndromes that you have to access, and it's really a burden to keep up with that. A lot of primary care providers would just rather send someone off and ask them and have them collect the family history. So again, that's one of the things that I will do is a full risk assessment on a patient, but it would be nice if we had electronic tools or a health record that would automatically collect that information and do a lot of that triage work up front. So our health record a lot of times doesn't even prompt us to obtain family histories. And again, it's not just screening and identifying and referring people, it's tracking the downstream management. After we identify people with genetic syndromes, it's kind of hard to know who's in charge of all of that. I think a lot of providers have this idea that patients don't think about these issues, but in fact, it's a really common thing now that people will come in and say, I have cancer in my family. I heard there's a test and I'd like to be tested. So I had a Hispanic guy come in to see me, and his father's cousin, and actually his cousin's two sons, had been diagnosed. And in this very extensive family, the word went out, this is a family disease, go talk to your provider. And so again, it was an opportunity to talk about preventive health. This is what competing demand looks like in an exam room. So every year we sit down and we look at all of the HEDIS measures and the things we report on in our chronic disease registries. We want to do a really good job providing adult immunizations. We want to offer a mammogram or appropriate cancer screening for every patient at every time when they come in. So we have standardized tools and check-in processes to address this. But there isn't currently a lot of either funding or reportable measures. You know, there's nobody's telling us if you don't do this, you won't get paid like they are for Medicare readmissions. And so trying to incorporate standard work around screening for family history when we're looking at people who are obese and we want to refer them for programs for weight loss, and we're looking at people who smoke and we want to get them involved in tobacco cessation. You know, these are the competing demands that we're looking at when I would like to standardize the way that we screen for genetic problems, and we do that by asking about family history. So this is just a cross-sectional study I did on all of the providers that are in our primary care clinics by specialty on their empaneled patients. So I looked at our electronic record to see if there was any element of family history, pertinent positives or negatives that were collected by specialty, and then specifically diagnoses that might be related to family cancer that was collected or cardiovascular disease. So you can see that my colleagues in internal medicine are doing a better job than a lot of people. And out of all of these groups of providers, there's one group that are consistently very good. It's a subset of one of these specialties. They're very good at asking about family history. Does anyone want to think what that is? It's our midwives in OB-GYN, I think, because they're constantly having conversations with patients about reproductive health and asking them about cancers and GYN health. And so I get a lot of referrals actually from our GYN clinics. When we take care of diverse patients, we have a lot of issues that they come in with. A lot of people have come from systems where they just really don't have a lot of access to healthcare. And so when they have family members with cancer or other diseases, they don't have a good diagnosis. And tools for providers to understand when we might want to change the threshold for referring people for testing or sending testing, I think would really help. Support groups to provide patients who have less health literacy tend to rely more on their health providers and health providers' advice, their communities, and their family. So I think resources that are more like patient support groups rather than just educational research, things that we can hand out will help a lot. And then some of my system issues are that we don't have a genetic counselor, so I don't have the ability to easily consult a geneticist. I talked about some of those strategies we have for optimizing a constrained resource like specialty care. And then it would be nice if we could have more than just grant funding for some of our self-pay patients to get them access to care. It is also difficult to do all that downstream tracking and management. When you've diagnosed someone, we also have to take good care of them. I wouldn't want to hand someone a diagnosis of a genetic problem and not be able to take care of them afterward. So those are just some of the challenges we deal with. And then the role of a primary care provider, since that is a pretty abundant resource for a lot of our patients. They have access to these patients, but I would just like clear guidelines as a primary care physician about what part of this is mine. So I haven't covered all these bullet points, but I've talked about a lot of the things that we can do or that we're lacking, and it would be nice if, what I would really like to see is that screening for genomic disease becomes part of the core services that we offer in a family health system as part of preventive health, as part of primary care. And just briefly wanted to mention that I'm working also with the CSER, which is funded through NHGRI, and they're working on exactly this issue, sort of opening up screening for adult patients using 2 online tools, so all of this additional burden of collecting family history would not be there, and then providing both testing and counseling over the phone with genetic counselors. So, and using that to develop a way of genetic counseling that is definitely focused on people with low literacy, that's more meaning-based. So I'm kind of excited about that project. And so thank you.